All right, just so everybody knows, we are recording.
So everyone behave. Yeah, I know I'm muted, even fine, go ahead. All right, so afternoon, everyone. Due to some technical difficulties on my end, we're actually gonna do not cases, but we're gonna go through Jerry trauma, which is one of the things that we transport a fair amount that I was able to put a full lecture together on. So for this one, come on, laptop, birthday. We're going to go through some of the physiologic changes that patients go through with aging, and then also some of the things to look at with geriatric trauma, which unfortunately with all of the assisted living facilities around here, we see not infrequently. Look at some of the literature around lift assisted falls, and then take a few minutes and look at elder abuse as well. As part of my research for this, there is some data that's actually relatively prevalent. And these are Southwest Ohio protocols that we're going to look at as well. Most of the cases that I looked at, they were pretty standard ones you'd expect: fall, hip fracture, none that were like terribly exciting cases for people to look at. All the management that I saw has been completely fine and appropriate, including pain control with appropriate doses of medication. But this was one that I actually took care of it Jewish for first case to look at, and I thought was worth sharing with people because it brought up a couple interesting points. So the woman that I had, she's 93. She was actually initially dispatched as a lift assist. And when squad got there, this was like the fourth time that they had been transferring her or like going out to do lift assist. And at this point, they noticed that she just wasn't quite acting like her normal self after having to help her get off of the floor from her ground level fall. And she'd been having a lot more falls at home. Relatively not a lot of medical history for 93, just high blood pressure and thankfully not on blood thinners. But family said that she's been losing all of her kind of functional abilities. And noticing some weight loss, her not eating as well, etc. Patient thought that she felt totally fine, but she was hypotensive for squad when they transported her. So she actually started in Jewish's trauma bay and got bumped out after some resuscitation. Her recent memory was pretty poor, but like her remote memory was intact. So memories from childhood over the last like few years, but nothing recently. Mental status fine. And she was a very slow walking woman who needed to use a walker to get around anywhere. And just looked like she was starting to become very frail. And my intern runs over to me after they start doing a skin exam, face white as a ghost, because this is what he ended up seeing on her breast exam. And when I saw it, she had erythema, so red skin, indurated, which is what it feels like, kind of like wet wood chips. It's from all the fluid seeping into the surrounding tissue. Hot, as well as like fluid pockets, like going from the breast up onto her neck and extending down her arm. At which point we both went, well, that's not great. And she ended up getting a much more advanced workup. Her family had no idea. And this was a family that was actually fairly well involved in trying to help take care of the patient, like helping get her food, making sure that like her finances were taken care of. One of her grandsons spent a lot of time with her. And the patient was your very typical little old mama who said, well, I didn't need my breast anymore, so I didn't worry about it, which was an interesting thought process. Because of the frequent falls and kind of slightly change in mental status, we got a head CT on her. And with that, she had some extra bleeding into a known subdural hematoma. So bleeding into a known area of blood collection. Her chest x-ray had something called inflammatory breast cancer. It is an incredibly aggressive form of breast cancer because unlike starting as a small chunk of defective cells, the cancer cells get into the lymphatic system. So it's basically getting into the small capillaries. And as a result, it spreads incredibly fast. It actually looks like a soft tissue skin infection. This one, I talked to a couple older physicians, and it's actually a fairly common thing they can see with some older patients who are starting to deteriorate, older females. And they won't have it go taking care of it because they don't find it too bothersome or not terribly painful, etc., until they start having skin breakdown. And by that point, it's incredibly advanced. So she ended up being admitted, and just due to goals of care discussion, etc., she elected not to pursue therapy. And then ended up coming in and was discharged like a few days later on hospice care. So I think considering the amount of calls of elderly patients that we end up transporting, it's worth spending a little time going over some of the physiology that goes with aging. One of my classmates sent me a nice little graph of like the expected age changes over the next few years for emergency department visits. In the age of like 65 greater than up, there's about a 20% expected increase across the US of such patients just due to our aging population. So it's good to go over some of these things in particular as a reminder. Getting older sucks. It affects pretty much every single organ system in the body. And what we find with that is that in general for the rest of the body, you start seeing a loss of a lot of the tissues that give us our functional ability. And it's not so much like most people think about as we get older, we start losing a little bit of muscle mass. And that's not, you don't care too much in like, your onesies you would bulk up. But what happens is a lot of people end up losing muscle mass in their stabilizing muscles. And that's what helps contribute to frailty. Other things that we see is like going through different systems. On the heart, of course, we know that cardiovascular disease is the #1 thing that causes people to die. Over time, all of those physiologic problems or insults that we've given our bodies, smoking, high blood pressure, eating horrible food, all of those eventually start to culminate in patients having problems as we get older. Start seeing changes in the heart, and they are far more prone to arrhythmias the older you get. So much so that in patients who have syncopal or fainting episodes, when they have them, they are at a much higher risk of it being a result of a potentially dangerous arrhythmia. AFib being by far and away the most common one, but VFib and VTAC episodes also common and can be harbingers of incoming problems with the heart itself. On the lung side, we start having patients that have decrease in their functional reserve in their lungs over time as well. And you also have breakdown or less effective hair cells in the lungs that help move the secretions out of the lungs, getting people much more set up to have pneumonia, which is why we see that much more commonly as we get older. The kidneys themselves, you start seeing a decrease in their overall function. And with that, you tend to see patients having worsening kidney disease as they get older. And this kind of goes in conjunction with some of that loss of muscle mass as well. You see those tending to go together. With that muscle mass loss, like I said, it's unfortunately a lot of the stabilizing muscles. So your core, your back, the ones that help keep you upright, help keep you from falling over, which makes them much more likely to have falls and damage. Skin becomes much more frail, and that's due to loss of collagen in the skin. That's why we see patients end up having much easier time bruising, much easier time having skin tears, because that collagen that gives the skin its elasticity and able to rebound is lost. The brain itself actually decreases in the cortex or the outer part of the brain. So you start seeing more room in the brain. In some ways that can be helpful. You have a little bit more room to accommodate blood if that ends up going into the brain. So say if you have someone who, like my grandmother who's 86, if she fell right now, even though she's on Eliquis, you may see the terror in my face with that statement, she has a little bit more room in her brain to collect blood before she's going to become symptomatic, unlike if I fell, because my brain is, I have more cortical space in my brain than my grandmother does. And I'll show some pictures on CT what that looks like. Another big interesting thing, your immune system. As you get older, this is one of the things I found on reading prepping for boards, as we get older actually, our body's immune system decreases to the point that we're not able to make an inflammatory response like we normally do in younger age patients. So that's why, say, patients end up having changes in the way that they present from a pain standpoint. Things such as abdominal pain, that's actually related to inflaming the peritoneum or the lining around your abdomen that requires an immune system reaction. So it takes more of a stimulus or more bacteria, more type of an insult to actually get your immune system to react. And as a result of that, you end up having to have like more sickness before you actually start seeing symptoms for patients. So that's why a lot of times when they come in and they're symptomatic, they're already much further down the road than we anticipate. So this is some of those pictures that I was trying to describe earlier. On the top here, you have a picture of a younger patient's brain. These black areas inside of the skull is where fluid should be collecting. In younger patients, what you'll notice is that all this tissue on the outside is a little bit more robust and there's less of this black area. On the bottom, this is a typically older brain. As you can see, those areas are larger, including on the outside, kind of on the periphery of the brain. See how these ridges and grooves along the brain are more pronounced with all of this more defined black outline. That's space that's filled with fluid and gives you a little bit more room to potentially fill with blood if you have bleeds in the brain as well. The downside of that, though, is that the veins that surround the brain, that means that they have more space to travel and they are more fragile because, again, of that loss of collagen, what helps build support around the brain. And that's why patients are also more prone to end up having head bleeds as we get older. Again, on that inflammation side, you end up seeing it harder for patients to develop inflammation as you get older. And on top of that, the white blood cells, the ones that actually give us our infection fighting ability, they are less effective as we get older. This causes us to have less effective immune response to bacteria, other pathogens, and on top of that, makes it us have to have more stimulus before we actually have painful problems. So say in an abdominal exam, if I have appendicitis, I'm going to have symptoms a lot sooner than my grandmother does because my immune system works better than my grandmother's does, and it will be able to pick up there's a problem quicker than my grandmother's will. On top of that, unfortunately, we do also have some cognitive changes, and there is, as we've seen in all of our runs, there's a difference between dementia and delirium that I think is always worth mentioning. Dementia is a kind of cognitive decline. There's a lot of things that can cause it, but is a progressive decline over time. With that, what you end up seeing for patients is that they slowly get worse over months to years without ever getting better. Delirium is an acute state, something that they can quickly go into, and we usually see it in patients who have some type of decreased neural reserve. So say as we get older, when we're already having some potential like cortical loss in the brain, sicker at baseline, if you give that brain a stressor, that can cause the brain to become delirious. Basically, kind of like the acute injury to the brain from some of those toxic changes in the body. And this is incredibly common. In the ER, they expect about on any shift, you would find about 10 to 20% of ER patients will have some form of delirium. That number may go up the more older patients you see in your department. I would say that number holds true on most of my shifts at Jewish that I see. And the problem with this too is it may make it harder to get history for patients as well. And I'm sure you guys have seen this too when we bring patients to the ER and the docs are always asking a bunch of questions and the patient's not able to provide answers. If we don't have good handoff from the nursing home, it can be challenging to help provide that for patients that have some of those cognitive declines or verbal deficits. This is the one we don't talk about as much, but I think we see functionally for patients, particularly when we're not in the hospital. And it's this idea that patients, as they get older, you start seeing functional decline and patients becoming more frail. And both of these sets them up to have increased morbidity as well as mortality. The functional decline is, can this patient actually take care of themselves at home? Are they able to get themselves to the bathroom, feed themselves, dress? Are they able to do things of that have higher cortical function? Like, are they able to pay their bills? Are they able to make sure they're taking all of their medications? Kind of as a general rule, the more people are able to continue to do, the more they will continue to be able to do. As you see patients get older where they're not able to keep up with much, that's when they start having drop off in their ability to live independently. So a lot of people will encourage anything you can do to help keep a person doing their own ADLs or their own functional cortical activities as much as they can, helps keep them independent longer because they're continuing to exercise that part of their brain. The other part of that though, that oftentimes leads to that functional decline is us getting more frail. Start seeing loss of bone, loss of coordination, loss of those stabilizer muscles, and neuropathy as well, the peripheral nerves becoming damaged as time goes on. And this makes people much more prone to have injuries that lead them to losing their functionally independent status. So think about your hip fracture patient who falls, they're not able to walk for a long time, and as a result, they end up losing some of their overall body strength, and then as a result, they can't, get themselves up to the toilet, and they have a much harder time building that strength back up again. And then as we talked about with the heart, much higher likelihood of ACS. As a reminder too, women typically will have a much higher likelihood of having the non-typical cause or symptoms of ACS. So that'll be maybe more so the nausea, GERD symptoms, but not that typical elephant sitting on my chest, left-sided chest pain. And syncope as well is known to have a much higher likelihood of leading to being caused by something more deleterious, like AFib, VFib, something like that. And I know that you've mentioned this before, Dr. Richards, but that pre-hospital EKG is actually really critical because that may be the one time we can catch the abnormality that's actually caused this patient to have that syncopal episode. I was just at the police academy earlier today, and we had a young gentleman syncopize, and we got an EKG pretty shortly thereafter, which shows some funky changes in the ST segment and some funky T waves. Which I'm happy we have it because now we can compare it. And if there's changes there with the hospital EKG, that tends to help give us a clue of what's actually going on with that patient's heart and what needs to be done to manage that. We see that even more pronounced, I would say, in elderly patients, at least from my experience. And getting an agreement as well from, from my mentor. Other thing too, and this is where we end up being a huge help on the fire side, is medications. Unfortunately, as we get older, and with the advent of modern medicine, we can pretty much treat all of your symptoms with the medication, but you may end up on 30 medications to help treat all of your symptoms. And guess what? They will interact with each other. Due to all of those organ dysfunctions we've talked about before though, once you start getting that combination of medications for patient, you can cause them to become more frail and have them to have a higher likelihood of having injury from polypharmacy. There's also some medications that are just not great for elderly patients, and there is a list that's compiled by geriatricians, the physicians who specialize in care of the elderly, and that's the Beers list. On that, there's some really common drugs that we give people that can cause patients to end up going into delirium or having other types of adverse effects. This can be common things like blood thinners for patients for obvious reasons, but when blood thinners, they fall, we now have a head bleed, that's not gonna be a problem. Opiates, we find that patients over time can have a harder time getting rid of those medications. Sedatives, same thing, it'll take lower doses to completely get them out. Hypoglycemics, medications of things like metformin, or even some of the other newer medications to treat diabetes can cause this for patients. Steroids are known to cause even young healthy people to end up having a little bit of agitation, changes in mental status, and we can see that more in the elderly, as well as worsening underlying bone loss. And then other ones is going to be the medications we put them on for blood pressure or the water pills. Each of those can compound, leading to electrolyte problems like potassium, kidney injuries. And then anticholinergics as well are just straight up known to cause delirium, even in young people if you get a high enough dose of them. And that can include really common things like Benadryl that a patient may take at home. They're really common to cause urinary retention for older patients as well. And with that can cause UTIs, etc. When you're looking at geriatric care, there is a big discussion from the geriatric side of looking at patients kind of as a comprehensive or holistic view. And geriatrics tries to take into consideration some things like fall risk, home situation, social supports. And some of the literature that I looked at actually talked about how they need to spend more time working with us because we actually go into the home and see what their home looks like. Imagine that. And even us having a better way to assess fall risk, saying, is this patient going to be safe at home? And that info being relayed to the providers can be really helpful. Like, hey, this patient tripped because there's rugs all over the house that need to come out. There's a bunch of stairs. This house does not look like it's being well kept, or like there's medications all over the counter. This patient's, the family member never showed up despite us trying to call them, things like that. That is actually really helpful to give your ER docs and nurses an idea of how this patient is doing at home. Are their medications accessible, labeled, taken care of appropriately, things like that. Geriatric trauma itself is managed a little bit differently than trauma in younger patients. And sometimes we get a little immune to this because we see it so often. But I will tell you that there's different ways that trauma in the patients over 65 is managed throughout the world, even than we do it here. So in the UK, they actually have this silver trauma, recognition major trauma in older patients. And they have a very different triage program that cuts down some of their activation levels so that it's much easier to get these patients evaluated from a trauma standpoint. Some areas like where I have family members practicing, any patient that's on blood thinners over the age of 65, they get a CT scan of their whole body if they fall down. I think that's a little insane, and some people think that's a little bit much. But there is what we know is that these patients that end up having trauma as we get older, they're more likely to have severe injuries with it. So this is pretty prevalent. This is actually almost 10-year-old data now, but about 13% of all of the injury-related visits to the ER were in geriatric patients who had falls was being the most common one. And unfortunately, things like falls is in geriatric trauma is the 6th cause of death in the elderly, with falls being the most common one. And I think we've all seen that. And I see that in the QIC reports all the time. One thing that is helpful to bear in mind is I've noticed people looking at this when they're doing their documentation here really well, is does the injury pattern match what you're seeing with the patient or the description of what happened? So, your patient that fell from standing height and they have a tiny little bump on the head versus, well, they fell from standing height, but they've got, trauma all over their whole body that looks more consistent with having been punched, kicked, thrown down a flight of stairs, things like that. And those are worth bearing in mind, particularly when we get to the topic of elder abuse or a little bit later. In patients who end up having injuries from trauma, what we find is that they tend to have worse outcomes than your younger patients that have the same mechanism of injury. The example I like to give is my grandma and I are both riding in the backseat of a car that gets in a car crash. Because I'm younger, I have more physiologic reserve. I will most likely not have the same types of problems that my grandmother would have sitting right next to me in the same car crash, same car. She's more likely to have broken ribs, have broken bones, have other types of organ damage than I am as a younger patient, unfortunately. When we look at the causes of trauma, number one is falls, and about 12% of adults that just live in the community will have falls every year. And about 4 to 5% of those that fall will die as a result of the injury sustained from their falls. And this doesn't mean necessarily falls from a height. This can include potentially ground level falls, with head trauma being a really big consideration, or some other type of medical insult causing them to have the fall. MI, arrhythmia being one of the big contributors. Second cause is MVCs. Again, because those patients end up with their less reserve, those lower speeds still end up causing decent injury to those patients. And the other thing we see interestingly in the elderly is the idea of, a low mechanism car crash, but your patient is incredibly ill. And it's probably because there was something medical that precipitated the crash. My own family example is my mom's dad passed away this year. He was leaving a Bible study and he crashed into a trash can, barely scooted it, and he was completely like GCS of 4, and it was because he had a massive brain bleed that led him to have a small low mechanism car crash. So you can see things like that, cardiac arrest, chest pain, etc., arrhythmias that cause them to have crashes, where we need to look at the trauma injury, but worry about something medical that led up to it in the first place. And then the number 3 cause is things like burns, and then injury or abuse, and including this self-injury, patients that may have underlying depression, which also goes up in age as we, for patients as you get older, you're more likely to have depression, leading them to either neglect caring for themselves or to actually straight up just do self-harm, including suicide rates going up with age. So the trauma criteria gets a lot softer for patients as you get older, and that is reflected in our own Southwest Ohio protocol. to try to help get these patients to trauma centers for evaluation. And that's because we find that these patients, if you get them to a trauma center, they actually do better. We found that you have a reduction, like their 7-day mortality, but we also find that we are less likely to take patients with geriatric trauma to trauma centers due to under triage, unfortunately. And most institutions have started putting together protocols to change the care for patients based on age, but it's not universal. UC, I know Westchester and UC downtown have some specific age cutoffs in their protocols. That's not necessarily the case with other hospitals in the region, though. Other things to consider that goes into this and is reflected in our protocol is some things like high blood pressure. You'll notice in the Southwest Ohio protocol that the blood pressure cutoff is actually higher to consider a patient hypotensive, and that's due to the prevalence of hypertension in the elderly population in the United States. I think our cutoff is actually at 110 for elderly patients that have a traumatic injury. You can consider taking that patient to a trauma center for evaluation and treating that similar to hypotension, with the presumption that they normally live at a blood pressure of around 140, 160. So this is akin to them having a blood pressure of 80. Similarly, patients that have dementia or cognitive impairment, it can make it challenging to assess their mental status. So unless you have a patient who's able to give you a full mental status and you're not sure if maybe this is dementia versus them having some type of neurologic insult, erring on the side of caution with those patients potentially taking them to a trauma center. And then anticoagulants changes their activation as well. And this can also include things like heart rate medication. So your beta blockers or calcium channel blockers. These patients may not be able to actually get tachycardic like we typically see in some of our patients with shock or trauma. So biggest things that we look at for trauma activation for older patients, number one is that decreased GCS. It's actually cut off a lot higher in the Southwest Ohio protocol. I believe it's at a GCS of like 13. You can consider that altered. Falls of any height, because we can't, they have looked. They would like to be able to find some fall predictor that says this elderly patient is going to be fine with this type of a fall, but this one is not. And from the literature that I looked at, they're not able to do that due to a lot of the other factors that go into it. So a fall from any height, including sanding, you can consider a potential risk for trauma activation. It's not universal, and we don't do that at every hospital, but it is something that you can consider as being a higher risk patient. Anticoagulant use, and then anything where there is two-system involvement, those patients tend to have a lot higher mortality. So if you see a long bone fracture and they have like hypoxia, you're pretty sure they have some type of rib fractures or belly involvement, those are sicker patients that need trauma eval.
And so I have a soapbox on this, which heard me say it before. Yeah.
I don't think I have.
So to go to that previous thing.
Absolutely.
So for you guys, when you're thinking about destination, these sorts of things, especially this, particularly for the geriatric population, these patients do a lot better if they're in a trauma center. They do a lot better if they're in a trauma center. That does not necessarily mean that they need like trauma bay, 10 people coming down to trauma bay when they get to the ED. So that's why, looking at your next slide, the Southwest Ohio protocol, there is an overlap, and there's a lot of overlap, but it's not a perfect overlap in terms of like what our Southwest Ohio protocol is in terms of go to a trauma center where they have like, you know, PTs who are used to dealing with like trauma patients and social workers who are used to dispositioning trauma patients, versus a hospital policy that says we need a trauma surgeon there within a half hour of patient arrival kind of thing. Like I said, there's a lot of overlap, but it's not perfect. And so calling ahead and saying, hey, here's our patient, and having the hospitals take it over from there is a good place to be in, because some of these considerations, and it's good to highlight in this context of geriatric, because it's really where you see it, there is a lot more that happens at a trauma center and why a patient should be there, rather than just that initial, like, I need 10 people down to the side, and know that they're going to a CAT scan.
Thank you. But yeah, so there's a lot of similar, we've covered a lot of it already, so things like the GCS, like a 13 or less, may be considered altered for patients, patients who are on blood thinners, long bone plus some other type of injury involvement, and then falls of any height, and that relative hypotension for patients are things that are worth considering for that evaluation at a trauma center. The things that most often get damaged for patients or the common injury patterns fall into kind of these 4 categories. Number 1 is TBI. Number 2 is going to be, I call them fragility fractures, and we'll talk about a couple of what those are. Fractures are problems in the spine, and then rib fractures. And rib fractures actually have a pretty high morbidity mortality in elderly patients. TBI, we see this a lot, is it can become in multiple different permutations. These are a couple different pictures of different types of head bleeds that we see in older patients. The most common one is this one here on the bottom left, and it's a subdural hematoma. So that's a collection of blood kind of on the second to most outer layer of the brain, and it's where there's venous blood that collects on the brain. The thing with the subdurals is depending on how much space patients have in the brain, then how quickly that blood is accumulating, that can help determine how much time these patients may have before they become totally symptomatic. And some patients can have like a bleed in that area, it stop and then bleed again, like that patient we initially had with multiple falls as well. At some point, if enough blood gets accumulated, you'll see what's happening in this picture here, where the brain is getting squished over to one side of the skull, and that can cause patients to die. The other types of bleeds we see, this is less common. This is an epidural hematoma. This is usually due to an arterial injury, and we see this a lot in like younger trauma patients where they got hit on the temple, causing a specific artery, middle meningeal artery is the name of it, but an artery on the temple to burst open. These patients typically will they'll fall out, or they'll become unconscious, and then they will come back and be totally fine for a certain amount of time until enough blood collects there that they then drop off, die. You don't see that as much in elderly patients. You tend to see that more in like younger, baseball to the head is the typical presentation for it. Other ones that you can see in older patients, spontaneous or from trauma, is this subarachnoid. This is this collection of blood in all the layers of the brain. This is looking at the base of the brain, and I think it looks like a splayed out chicken. So I call it the chicken of death. Other people have called it the starfish of death here with this 5-pointed collection of blood. And those are the patients that'll oftentimes come in potentially really hypertensive, barfing their guts out. And you can see this in patients after trauma. And then the other one is the bleeding into the brain tissue itself, or an intraparenchymal hemorrhage. These tend to be really hypertensive, also barfing uncontrollably. In the fragility fracture category, hip fractures and femur fractures are going to be your biggest ones that you're going to see for patients. And we see these actually a lot, particularly patients that fall down there now complaining of pain in their groin. It's probably a hip fracture is one of the big things we'll look at. In these, even ones that don't require going to the operating room, these can still end up causing patients to have a huge likelihood of losing their functional independence or actually dying. We found that some patients that have hip fractures, when you look at them 1 year out, about 45% of them ended up passing away as a result of them losing more of their functional reserve, complications with having to have decreased mobility, being in hospital, post-operative complications, etc. The other one that's common is, and I've seen this a lot going through QIC reports, is the FOOSH, or the fall on the outstretched hand. You may use that acronym if you like, the FOOSH. On this one, the ones that are often affected is going to be the wrist when they fall and try to catch themselves. Or if they land on their elbow, the other thing that gets broken and will look potentially like a shoulder dislocation is they'll break their proximal humerus. And on this one, they're going to have some incredible pain up on this upper part of their arm and not want to move it. And I've had some patients where they'll have that one of those fractures. They don't have to do surgery on it, but these patients will be confined to a nursing home for the next 6 weeks, and you just see them drop off after that because they can't live independently if they've no one at home to help take care of them. In who's at risk for this, it's going to be patients who have a likelihood of having osteoporosis. So this will be older female patients over the age of 50, because estrogen actually is what helps us keep calcium and other nutrients in our bones. So once women go through menopause, they're more likely to end up having fragility fractures, and they can have it younger. Men, as they get older, just due to age, over the age of 70 is the other ones at risk. And then patients with poor nutrition, so patients not taking enough protein, vitamin D, calcium. This is one of the examples of that wrist fracture, where you can see the bone kind of like crunched back on itself. And a lot of times something like this will not be treated operatively, but say if that's a patient's dominant hand and they need that to use their walker to get around, they are not going to be able to function independently at all. Vertebral fractures, which is going to bring up a fun thing for us to talk about, C-collars. Fractures in the spine. These are not terribly common in only about 2 to 6% of all falls. But the ones that end up having them, they can have a very high mortality. Like in this, one of the studies I looked at was about 32% dying about 1 year out after having their fall. And what we find is that their fractures are pretty high up in the spine. So it's C1 or C2. And that's due to, as we get older, we end up developing this kyphosis where all of our patients are slumped over this way. So it's much easier for them to have an extension or a flexion injury of their neck when they fall. And then the other one lower down in the spine will be things like compression fractures. And these are, you can often see for patients that have underlying osteoporosis or undiagnosed cancer. That then causes them to have these fractures that pop in. And they may not have many symptoms at all other than a slight bit of pain in the area. Bless you, not all patients that end up having these fractures need to be necessarily like be put in a C-collar. There's a big movement in some of the areas around the world to go away from C-collars, including in the UK. And what we have found is there is some potential deleterious effects or some problems for putting all of your patients in C-collars. The ones that I would say to be cautious with are the ones who you cannot rule out on exam that they clearly don't have any injuries in their neck. Patients who are able to talk to you, they're awake and alert, and are able to say like, no, I don't have pain when I move, or when you push on their neck, or with neck range of motion. Those are ones that you can have a discussion with and truly assess. They probably don't need one. Some of the lit though that I looked at when it comes to C-collars, because this is a contentious area, the overall literature seems to be moving away from putting C-collars on older patients. Like I said, the UK doesn't do it at all. We don't mention it in the Southwest Ohio protocol anywhere. And I looked at actually some literature, including from neurosurgery, funnily enough, and they found that there's the risk that they have is really high risk of doing pressure sores creating pressure sores for patients by putting C-collars on due to their poor skin. It can also mask other injuries, and because of that decreased lung reserve, if you put their hunched over and you put them in a C-collar, it may make it harder for them to breathe. One of the studies I looked at showed that most patients in the ER, between their C-collar being put on by EMS and until they actually get it taken off, they're in it for over just about 2 hours, 117 minutes. And that is enough time for a pressure sore to start developing on some of these patients' shoulders and on their necks. Same thing with backboards. So the general consensus I found is that there's concern for neuro findings. So there's a deficit. There's like a motor or a sensory deficit. Then looking at doing a C-collar. Otherwise, you don't necessarily have to do it, was the literature that I found. Do you have any thoughts on that, Dr. Richards?
Yeah, I think certainly if you do end up having like focal neurological deficits, it's just gonna go back to C-collar in place. If you have someone who's altered, they're compliant with it, and you think you can get to your way, okay, then I'd probably have to go on. But if you're not having neuro symptoms and it's gonna be causing the patient, just shifting around because they're confused because they're anterior baseline, I think you kind of work the best way to just do, spinal motion restriction as best you can. But that concerning exam finding as best you can, probably it's better to kind of have that in place. I mean, sometimes it just ends up being kind of a little relaxed patients as well as you're doing that somewhere. So they're not just
Completely scratching around.
But yeah, it's making things worse.
And then the last category is thoracic trauma. And this one has really high mortality, about 3 to 15% die while they're in the hospital after their initial injury. Most common stuff being fractures to the ribs or to the sternum. And then the last one is lung contusions. So they end up actually bruising the lung tissue itself, oftentimes behind the rib fractures. The problem with these is that they end up at a really high risk for pneumonia due to them not being able to take deep breaths and then them having difficulty clearing their secretions, which can lead to respiratory failure and them losing some of their lung status as well. So as a result, most trauma hospitals will end up being very aggressive. So if they have more than 2 rib fractures, plus they're old, and the oxygen requirement, a lot of them will go to the ICU to watch very closely for respiratory failure, as well as to get them in aggressive respiratory therapy. So they do like a lot of work with incentive spirometry so they keep breathing, a lot of work getting them up, moving around. They may even look at doing like spinal blocks or things like that to help control pain, to help keep these people from developing pneumonia. And even with that, they may still end up with a sniff. I've seen patients that are like 85, 2 rib fractures, and because they're on a few liters of oxygen, they need to go to the ICU, and they develop pneumonia not that long afterwards. So it can happen, unfortunately, some of these other factors. So for us, we talked about some of the big things here, which is going to be taking a look at their blood thinner status, doing a really good primary assessment of these patients. It's really helpful for us to know when they last took their blood thinner, because that helps with some of our need for reversal discussions for some of these patients as well. And then some of the consideration for patients to go to a trauma center. I did take a little bit of a perusal through some of the literature on lift assist when I was putting this lecture together, because unfortunately these are really common. It is also an area that's growing in concern from the pre-hospital side because it's such a common call type. I did have a good laugh because one of these journals, I think it was the geriatric one, actually had to describe what a lift assist was and went through actually saying like it is a call that goes out where you just go and help get a patient off of the ground. I presume for someone who's had no experience with EMS, but I had a good chuckle reading through. I was like, yeah, that sounds like multiple calls that I've already gone on before. They described it specifically as one that results in a non-transport. So help the patient get up, do a chart, and patient stays at their house or wherever they are, their institution, etc. The most common locations was in someone's bedroom or bathroom where they're not able to get out the toilet, which I think holds true from what a lot of us have seen, or they're stuck in their bedroom, fell next to bed. And one of the papers actually looked at what types there were, and it was most often like a slip, a trip, or a slide as their description, and it was often women, and they were more common in the morning. So I'm curious if that would hold true with what you guys have seen on runs, but that was what came up in some of the papers I looked at. However, unfortunately, what they find when they look at these in some larger EMS systems is that these lift assists may end up being a precursor that this patient is actually secretly either having some functional decline, some difficulty from a fragility standpoint, maybe secretly sick, and that's what caused them to fall. So that's kind of associated with a little bit higher mortality for them. This was a paper that LA looked at, and they looked at the 14-day morbidity and mortality for patients that had lift assists. Also, fun fact, it was about 2% of all of the calls in LA County Fire's EMS system. And out of those, 21% of those patients that had lift assist, when they went back, they had to go to the ER. 11.6% of the patients ended up being admitted, and about 1.1% of them ended up dying later on. The UK also did a similar study where they looked at 6 months of data. And this was anyone that contacted EMS. This looked at both the dispatch data as well as the data that went where EMS went out to people's homes with their slightly different EMS system. And those patients that they went out for lift assist, they found about 9% of them had to call EMS back to their home for more care. 12.6% of those went to their admitting an emergency, which is their ER. 6% of them got admitted, and about 3% of them died within 3 days. Same thing again, where these patients ended up having a little bit sicker problem that led them to having their initial fall and then having people come back. So big shocker, this is an area that they're spending a little bit more time in research at. I know when I was at NAEMSP, one of the educators out of Rochester, I think she's in New York, is specifically trying to look at this area, because we're seeing this trend with these lift assists becoming more common, especially with their aging population, that we may need to have a better way to look at some of these to help characterize who these sick patients are. They're gonna need to potentially take it from a lift assist to a transport early to prevent callback for a worsening morbidity mortality. But we don't have that data yet with it. Interestingly, they did find that the patients that were at a greater risk of needing that callback were patients who were older, and if there was a record missing from the initial ambulance call. So you can see from the dispatch data it was a lift assist, but supposedly they didn't actually complete like a PCR on the patient. And what ends up happening with these patients, they end up having those fractures, TBIs, but then also medical problems. A big one being rhabdo. So they fall down, they're stuck on the ground for a long time on their second fall, and then they have muscle breakdown that leads to kidney failure, dialysis, and death. Sepsis, another one, and then the patients having delirium, which is worsened with them then staying in the hospital afterwards, and then as well as these patients becoming more frail over time. The other fun thing with this is that there is a focus now that a lot of specialties in medicine are getting into, and thankfully they're tapping into EMS to help with this, to try to help prevent some of these falls and prevent some of these lift assists. But this is an area that's going to be growing, I think, over the next few years, given our aging population. This can include some things like there's a huge push from the community paramedicine side nationally about having people actually go in and evaluate these people's homes. Just go check on some of our older at-risk patients, you know, are you taking your meds okay? Did you like need anything to get your appointment? Get their, do a fall assessment, things like that, or even help with linkage to care for them. And I think that's one area that community paramedicine would actually be very helpful, with going to see where people live and taking a practical eye to it, that as much as I love medicine, sometimes we just don't get to see as much. And then the last thing, which is a sad thing to end on, is elder abuse. This is, I was surprised how common this is. About 10% of all adults in the community over the age of 65 end up qualifying for elder abuse, and about 20% of patients in nursing homes end up having elder abuse of some permutation. These patients, of course, also are more likely to be seen by EMS as opposed to going to the ER or their doctor. And on top of that, they're 4 times more likely to call us to end up giving care to these patients and or police. Both on the who is more likely to inflict elder abuse and be a victim of elder abuse. Some of the things that are in common is, unfortunately, patients that either they're functionally dependent, so the patient being dependent on a family member for care, or someone being stuck with a high degree of caregiver burden. Have family history of prior violence, substance abuse, and then also things where the elder is dependent on where the caretaker is dependent on the elder for financial support. I also found out that reporting is incredibly low. Only about 1 out of 24 cases gets reported. And the most common one that gets reported is financial abuse or neglect, but the less common ones include things like physical and sexual abuse. It is required by Ohio that we report it, and if you end up having to make the phone call, particularly to give a report on a nursing facility, I will tell you that it is not the same number that you do for Ohio. They may end up directing you to a different line from, say, just your standard elder abuse call, because it actually has to be reported to the state if a nursing home is causing problems, because they are designated by the state, and that goes for group homes as well. Most of us have seen things like the physical abuse, neglect, see it all the time, unfortunately, for patients stuck in SNFs. Abandonment is another one that does qualify, leaving an elder somewhere without the ability to get home. Emotional inclusions is another one too for patients, say like helping or creating situations where they're more anxious, depressed, not getting them their psychiatric care they need. And then financial is another really big one.
It's, I mean, this is particularly vexing. No, some respect, but like in another population, because like they may have an element of dementia and that may be manifest by like paranoia, and so like easing out, like you know, paranoid dementia versus, you know, elder abuse, or, you know, she, you know, don't want to like be placed into a nursing home or something like that by her family, but like it's just tough. So
Yeah,
obviously, again, just another to reiterate that like we're not investigating any of this, we're
Nope.
just, you know, keeping our eyes open and reporting kind of what we see, and then
Yep.
folks on the back end take it from there.
yeah. All that's needed is a good faith consent. And having looked into some of this, it has actually changed my own practice pattern, where now if I have a concern, I have a much higher or a much lower threshold to actually call and have someone take a look at people, where they live, get some more information and make sure that people are safe. And it's actually pulled a couple of people out of some different group homes after learning some of this material. The things that are helpful to pay attention to, and I didn't think about as much, to be honest, most of us will pay attention to living conditions. Is the place squalor? Are they sitting in their own filth for hours on end? But then also, like, how does the family interact? So does like if it's a family member giving care to the elder patient, are they allowing their family member to provide their history? Is their interaction seem like it's healthy, kind, as opposed to more coercive, which can be seen as well? Does the elder seem to be having a lot of fear with the provider, etc.? And then other things include, like, does the injury match the pattern, which we talk about all the time, particularly with kids. I think we talk about it a lot. You know, say the kid that says, I fell down, and you look at them like, no, you totally fell down a flight of stairs. Same thing with older patients as well. But then also taking a look at their medication. Do they have access to it? Is it labeled that they can clearly see what it is? Because and medication diversion being another big one, and that may be more medications than we think of as people find different ways to use drugs over time. These were some of the patterned bruising, or like different types of bruising that I found that's worth just paying attention to. This up here on the top right is a ligature. We can see this on elder patients that have been unfortunately restrained. This bruising on this older patient was from being assaulted by a family member, where they got kicked and punched. So these ones kind of on the chest or the torso, the big areas where we see it is going to be on the upper extremities, the face, and the chest. Injuries in that area should have some attention to make sure that it fits the injury. So, you know, patient fell down, says I hit my head, they've got a goose egg here, that makes sense. Patient says I fell down and they've got a hematoma on their ear, and then they've got something on the other side of the face. That fits more with an assault pattern. This here, actually, these bruises in the groin, was a patient who was demented in a nursing home and was sexually assaulted by a provider there, and the bruises from trying to hold the legs open. So injuries in that area are always worth paying attention to. We see pressure sores all the time from patients, unfortunately, sitting in their own filth for a long time. But then also looking at things like, are their nails cared for? Is their skin cared for? To give an idea of how well they're actually having their toileting and their personal hygiene being taken care of. If there is clear concern for elder abuse, we can have law enforcement get involved, as well as adult protective services. There is situations though where, just like in patients say who are victims of domestic violence, they may still refuse to have involvement from law enforcement. And if your patient is has the cognitive ability to refuse that intervention, they may, just like a patient who decides to stay in a potentially volatile domestic abuse situation. They do have that right to do so. If they don't have the cognitive capacity to do so, though, we need to stick up for them and let other people sort it out. There is this thing called self-neglect that I ran into, which was also pretty high in older patients. And this is often where you have untreated depression or anxiety, and these patients just stop caring for themselves. And that is also a situation where we intervene for those patients and may even put them on like a 72-hour hold. They're basically an untreated depression type patient who is not taking care of themselves with the hope of dying as a result of it. And in that situation, you essentially treat them like a threat to themselves, because they are, just by omission or by lack of effort, etc. So those are some of the big things that I had for older patients that I wanted to go over with people, some physiology, the trauma patterns to look for. as well as a couple other less happy topics, and happily go over any questions or thoughts from people. And next month, we will be doing a ton of cases, because I will be making them for months.
Still good topics. Any questions from anybody? Very good.
Cool, thank you.
All right, thanks, guys.